But
Hello, everyone. I'm Ashwin Kadambi, and it is my pleasure to welcome you to this incredibly important event, improving access to mental health services in the United States. By the end of this interview, I can promise you that you will leave with a clearer understanding about the major bottlenecks and barriers to addressing mental health services, to accessing mental health services, more importantly, by people from minority backgrounds. This month, May, is marked as Mental Health Awareness Month, and we are incredibly honored to have a guest who's not only an accomplished scholar, but also a professional with significant experience working with people from diverse communities. Each year, millions of Americans face the reality of living with a mental illness. Even before the COVID-19 pandemic hit, the prevalence of mental health conditions in the nation was in the rise. In 2019, nearly 52 million adults experienced some form of mental illness, and recent data from CDC shows that 1 in 4 adults have experienced either symptoms of anxiety or depressive disorders in February 2021, which is a significant increase from the previous year. And if we look at the statistics, it is also shocking to see that 1 in 6 US youth aged from 6 to 17 have experienced a mental health disorder each year in the past decade. And if you look at the annual treatment rates among US adults with any mental illness by demographic group, especially if you see males, only 36.8% have went out and seek treatment for mental illness. If you look at Asian community, only 23.3%. If you look at the LGBTQIA community, 49.2%. Hispanics, 33%. So this kind of data is not only shocking, but it is time to recognize it as a public health crisis. And there's a lot of misconception, stigma, lack of awareness, lack of information, and the ridiculing attitude that's still prevalent in the society. We hope that conversations like these will destigmatize and offer a clearer picture about the problem at hand. And we need to fight stigma, provide support, educate the public, and advocate for policies and support people with mental health illness as well as their families. It is time to treat it as a public health crisis, and that it is, and reverse the trend. Let me, with no further ado, turn this virtual podium to my co-host, Helia Ghaffari, who will introduce our guest.
hi, thank you for the opportunity to host this very important topic with you. So I'd like to introduce Dr. Brittany Rivero. Dr. Brittany Rivero earned a master's degree and a doctor of psychology in clinical psychology from the Chicago School of Professional Psychology. She's currently completing a postdoc at St. Joseph's University, Counseling and Psychological Services, where she works with college students presenting with a variety of mental health concerns. She previously completed part of her training with the DC Superior Court, completing a psychological assessment with juvenile offenders. Additionally, Brittany has experience completing neuropsychological assessments with individuals ranging in age from 20 to 80s. And Brittany's clinical areas of interest are LGBTQ issues, eating disorders, anxiety disorders, and she is passionate about providing therapy in university counseling centers. Additionally, she enjoys providing supervision to clinicians in training and hopes one day to become a training director. So welcome to the show, Brittany.
Hi, thank you so much for having me. It's an honor to be here today.
So we'll jump right in. On April 30th, 2021, the Biden administration released a proclamation on National Mental Health Awareness Month, recognizing May as a National Mental Health Awareness Month. In this proclamation, he discussed that isolation, sickness, grief, job loss, and food instability and loss of routines have increased the need for mental health services. And that job loss means also you losing your health insurance and therefore access to mental health services. So as the country opens up and returns to normalcy, what are some ways that the cost would remain to be a significant barrier to accessing mental health services?
It's a great question. So I think it's important to understand that insurance isn't always great about covering mental health services. Insurance has traditionally focused mostly on physical health. So even individuals who do have insurance coverage, that does not necessarily mean that they will be able to access mental health services. If we think about some insurance companies don't cover mental health services at all. Some of them will limit how many sessions they will cover. So it might be 6 to 8 sessions. But I can tell you that if I'm working with someone with, for example, PTSD, 6 to 8 sessions likely isn't going to be adequate. It can be helpful, but it's not going to be adequate to get them to a place. And actually, sometimes working with trauma, you unpack a lot of things and then that doesn't give you much time to wrap it up, so you can actually almost do more harm in that type of a situation. Also, we have to think about copays. So typically when we see a physician, maybe a primary care physician, you pay maybe a $30 copay, but we're typically not going to see our primary care physician as frequently as we would a therapist. If you're going to therapy, you're going to be seeing your therapist probably weekly or at the very least bi-weekly, which would be every other week. And so you're still ending up having to pay, maybe it's $30 copay, you're paying almost $100 a month in addition to whatever it is that you pay for insurance. And this is assuming that someone is insured. So as you can see from just even those aspects, having an insurance plan and having insurance does not mean that mental health care is affordable. It's pretty rare to find insurance plans that will fully cover mental health benefits and don't charge a high copay per visit. And typically you'd be paying a lot of money for that insurance plan. So I think that's a real barrier. And then we have to consider people who aren't insured. We have community mental health programs throughout the country, but a lot of times these are underfunded and understaffed. And it can be challenging to be able to meet with a mental health professional in a timely manner. A lot of times the mental health professionals are very overwhelmed. They have extremely heavy caseloads and burnout is very high in those different fields. So I think that's a certain barrier in itself, that even if those services are available, they're difficult to access and maybe aren't the quality of the services. Not to say that community mental health isn't quality service, because they absolutely are and have fantastic clinicians, but they're human beings trying to balance caseloads that are way too big. And that's just unfortunately what happens a lot of times, especially in underserved communities that maybe are in lower SES kind of areas. So I think accessing mental health services, there are quite a few cost barriers, and sometimes mental health providers don't even accept insurance because they don't necessarily have to. And when you think about the cost of going to school to become a psychologist, a lot of people end up hundreds of thousands in debt. And so those clinicians have to pay off those student loans. So they can't necessarily take jobs in certain fields that maybe don't pay as well. So, I mean, there's a lot to it. And we have to consider all of these factors. Some clinicians will offer services on a sliding scale, which can help. So essentially it's looking at how much a particular client makes and then adjusting your rate based on that. Some clinicians will take pro bono clients. We are encouraged to do that within the field as much as we can allow. But then again, you have to balance paying off student loans and cost of living just in general. So those are just some of the initial barriers that come up just related to cost.
I'm glad you mentioned about also people that are uninsured, because so right now I'm working at a city hospital, public hospital, where a lot of our patients are uninsured. And compared to our private hospital, it's actually really amazing to see how many more of them have untreated mental health conditions, especially a lot of alcoholism, which is, a lot of things. We have to remind people that is a mental health condition. And there is this very strong correlation between poverty and mental health. And, it's kind of one drives the other. And it's this vicious cycle. But, so this is, and it's actually, you see it visually because at the hospital, the patients that are also have psychiatric conditions wear a different gown. And when you walk through, you see how many of these gowns are there. And it affects their ability to take care of other health conditions. Like, one that's obvious is liver cirrhosis with the alcohol use disorder. But there's also people with very extremely poorly controlled diabetes, losing limbs because they're schizophrenic, and they have schizophrenia, and their schizophrenia prevents them from getting a job, and then they get in homelessness. They can't take care of theirs. It all ends up this vicious cycle. So I'm glad you brought up a lot of these things that really did exist pre-COVID. I think that unfortunately, as things go with mental health disorders, when a condition affects more people, it brings it more to the surface. So I think that happened with PTSD. I mean, correct me if I'm wrong, but I believe that PTSD became more of a concern for people after 9/11 because it affected civilians.
I would imagine so. Actually broadened in the DSM. So if you look at the Diagnostic and Statistical Manual, so that's how we diagnose. Within the fairly recent history of the DSM, they broadened PTSD to include first responders and include people who had witnessed traumatic atrocities. Whereas previously, first responders were not considered as being essentially eligible for a PTSD diagnosis. It was really only essentially for, I think, combat veterans back in the day is kind of where PTSD sort of got its initial research and became a diagnosis. But now it's, been broadened to reach more people. And I'm really happy that it has, because I think it has lifted some of the stigma on a PTSD diagnosis.
And Dr. Rivero, in terms of, within the topic of the cost itself, are there examples from maybe different other countries or within the United States itself, if there are any pilot projects that have been done where the cost model has actually improved access in a particular community?
I mean, I think a lot of you putting more money into community mental health is really where I think, at least in the US, I can't really speak as much to other countries, just given that I've only practiced in the US. Sure. And other countries tend to have different medical models in which, if there's socialized healthcare elsewhere, that's something that they would handle that differently. So as far as sticking to our current model in the US, the way that I think we can expand access to mental health services is through putting more money into community mental health, because then we can open up more community mental health centers. The clinicians who work there are not going to be so overwhelmed. Really, a lot of that has to come from recognizing that, as you said, it is a public health concern. I mean, and especially now post-COVID, it's really, or I don't know if I can call it post-COVID, but as things are returning, right? As things are returning more to normalcy, we are really seeing mental health is really struggling right now, I will say, just in a widespread way that we probably haven't seen in a very long time. So I think the goal here is maybe to put more money into the community mental health centers and putting them in places that are typically underserved. Because if transportation is a barrier, if someone lives in an area that they, and they don't have access to transportation to get somewhere else that has a community mental health center, that also creates a barrier. There's so many steps to getting there that we need to address. Also, knowing if it exists. Some people wouldn't know to Google community mental health service in my area. I mean, that's just, I know that because I'm in this field, but that's not public knowledge, I really don't think, or it's not enough public knowledge. So people don't know where to access the services. Once they do, the services are not funded enough. And I think those are some of the barriers. So trying to create, and also preventative programming as well. I think creating programs, and I could go on about preventative programs, but I think prevention is such a big part of trying to address some of these mental health concerns. Is not letting them get to a place where it's so difficult to treat. If you can try and prevent some of these mental health concerns from getting worse. It is
It's also like, sorry to cut, but it is also like usually neglected area within any healthcare condition. Usually we see the non-communicable diseases. The investment into prevention is usually much less rather than into the treatment, where the money is more, where there's more opportunities to make money. And thank you also to Helia for bringing up that conversation about labeling patients with mental health illness. So, we have these invisible labeling in the community as well, where that is, it's automatically increasing stigma. We see this kind of a behavior from the elementary school students level itself, where that kind of public stigma versus self-stigma exists, and also, encouraged sometimes in the households due to, lack of awareness. And from your practice, Brittany, how large of a part does stigma play from preventing access to, preventing access to mental health care, especially for minority populations?
Very large. Stigma plays a huge role in people not seeking out mental health services. Specifically minority communities, there tends to be more of a stigma on having a mental health condition in certain minority communities. I know at the beginning you read off some statistics about minority communities and quite, in my opinion, low percentages seeking out mental health services. And I can guarantee you that those percentages do not reflect the mental health concerns within those communities. They're much higher, but people are just not seeking out services because there is a stigma. I hear from a lot of individuals who I work with who maybe are from minority communities that they have been taught that mental health is a sign of weakness, that anxiety is them just being nervous all the time. Oh, don't worry, oh, good, it's cured now. Because they told me not to worry, therefore my anxiety is cured. And then depression is seen as, quote, laziness. So there's just a lot of this, just such a stigma on mental health concerns. You brought up substance use. It is absolutely a mental health condition that I think is treated almost as a character flaw in our society. when it's not. I mean, it's, obviously it does come with interpersonal struggles, though that's not to diminish the fact that substance use disorders can absolutely impact the people around that person and make relationships difficult, but it's a mental health disorder that needs to be treated. And I think, not to go off too much on a tangent, but even just looking at our justice system, we treat substance use as a crime versus a mental health disorder.
Yeah.
And so, I mean, that's just one example of how our legal system stigmatizes mental health. And a lot of times people don't have access in our legal system to the rehabilitative services that they need, or, it's not enough. So stigma is a huge, huge, huge barrier to people seeking services. I know that sometimes when I do work with individuals who have that stigma, it's almost walking into the office, they're kind of like hiding themselves. They don't, they have their sweatshirt, or they're looking down, or they're in the waiting room doing some of this because they do not want anyone to see them. They'll ask me a million times, is there any way my family can find out that I'm here? They wouldn't be okay with this. So, I mean, there's just, I can always tell pretty early on if someone comes from a family where mental health has been stigmatized, or a culture where mental health has been stigmatized, because they're acting, I mean, they're essentially hiding in the room and making sure no one can find out.
Yeah, definitely. I can relate this to our Asian community, where, they either think that mental health is something that doesn't affect their family or their children, but, it can become too late at some point, and it's definitely a huge issue impacting access to mental health.
Absolutely. And these conversations are crucial. It's so important to talk about the stigma. The more that we talk about something and the more that we're open about that experience, the less stigmatized it becomes. So I'm glad that May has been deemed Mental Health Awareness Month. I think that's one step in reducing stigma surrounding mental health. We have to continue with having these conversations. The same way we might talk about breaking a bone, we should be able to talk about our anxiety, because at the end of the day, they're both, disorders that are just impacting different parts of the body, essentially. And sometimes I find that working with my clients who do have that stigma, or have associated that stigma with mental health, I try to make it like a physical health concern. I explain to them, if you had a cold, wouldn't you go to the doctor? Wouldn't you, do something to treat the cold? How is anxiety any different? How is depression any different? So that's sometimes how I get people on board, is trying to take almost like a physical medical approach to it. And ultimately, a lot of mental health disorders really are neurotransmitter issues. There's a shortage of serotonin. That's where a lot of anxiety and depression comes from, if you're looking at just the neurobiological components of it. There's a reason medication helps. So it is also a medical concern too. It's, we don't think it's nurture in nature. So that's what makes mental health, I think, a little more complex, and makes me, I love it. I'm very biased and passionate about this, but there tends to be the nurture and the nature. And so sometimes pointing out that nature component with my clients can be very helpful. So I have found that's one way to sort of reduce the stigma a little bit, get the buy-in.
Something I'm impressed with when I worked with psychiatrists and psychologists is their approach to when they treat a patient. It is very similar to the way, like, I treat a patient that comes in with like a inflamed gallbladder. Like, there is a very mathematical approach to it. Like, you talk about milestones, and so I think that's another way that it emphasizes what you're saying about, like, it is part of your body. It is a disease, and it's not like some wishy-washy, I don't know what you call, like it's not pseudoscience, it's a science. And just because we don't understand how the brain works quite to the depth as we know that the heart works, doesn't mean that it doesn't need that attention.
Right, and the distinction there, which I think is really cool, is we're talking about the brain versus the mind. And we understand pretty well how the brain works, but the mind is what's kind of is what makes this, to some people, feel like a soft science or a pseudoscience, as you had kind of said, and I've certainly heard before, is that the mind is very complex. It's not as easy as, that do this, do that, and it will be fixed, because there is that nurture and nature component. So yeah, brain versus mind is a really interesting distinction that we tend to make within the field. So thank you for pointing that out.
Yeah, kind of along those lines of using our understanding of the brain and the mind to help people. The Mental Health First Aid training can help every police officer serve their communities as well by providing them a critical skill to respond safely and responsibly to situations, the same way that healthcare workers are trained in the hospital setting. So like involving people with the mental health or substance use disorders. So there's a suggestion to bring a trained mental health professional when responding to crimes or encountering assailants, which approach is more sustainable.
So that's I guess hot button topic right now. It's very much in the news and being discussed in our current news and history. And I think we have to consider all of the different aspects of what this might mean. So one alternative that people have discussed is teaching police officers how to de-escalate these situations, how to be able to read when it's a mental health concern. For example, if you have someone who has schizophrenia and they are actively psychotic at that moment, essentially trying to de-escalate them and get them to a place where maybe they're not going to be a danger. So that's one alternative, is teaching cops how to do that, but that's a very lofty goal. We spend years learning how to do that. And that's, our primary focus of our job for a lot of people, is really learning how to de-escalate and work and assess in those situations. So I think it's a very big ask to expect our cops to learn how to do that. We're essentially asking them to have two jobs, which doesn't seem realistic to me. I think further training in mental health for our cops is a great idea. I think really is honestly a great idea for everyone. We should all have more training in mental health, but I absolutely think we should be training our cops more. I will say that they are piloting programs now. I saw that actually on June 1st in DC, they're piloting a program in which they will be sending unarmed mental health professionals to calls that are deemed not violent, no weapons. And the goal behind this, from what I heard, I believe it was a Washington Post article, they are trying to de-escalate the situation because there is this understanding that if someone is, for example, actively psychotic and might be struggling with delusions and they don't quite understand what's going on, having a bunch of cops come at them can be very activating and can make a violent situation end up occurring that wouldn't have otherwise if you send in someone who is unarmed and a civilian and can talk them down. But I think we also have to consider the safety of the mental health worker, because, let's say that someone called in and said we didn't see a weapon, or the person who's actively psychotic maybe was a little more de-escalated and then has escalated more since the call in the time it takes you to get there. So I think these are things that the pilot programs are going to shed some light on. How can we find that balance of trying to keep civilians with mental health concerns safe? How can we keep the mental health providers safe? And how can we kind of have everyone working together in a way that can achieve the goal of essentially not escalating situations that are not related to a crime? Because someone who's actively psychotic in that moment, they're not committing a crime, but they do have the potential to. At that moment, they might be scared. They might get violent just to defend themselves because they don't understand what's going on. So I think safety is the number one thing that jumps out to me. So I'm really, really interested to see how these piloted programs go. And I hope that throughout the piloting, people are kept safe and that, there isn't any tragedy that comes through that. But I think also individuals who would take that role doing that probably recognize that there is some level of risk in having that type of a job within the mental health field and are signing on knowing that there is a risk there. So I think that's important too, is, we're not just forcing people who don't want to go in and do this. I mean, these are probably going to be people who volunteer and want to do this. So it's a very, very nuanced question situation. There's a lot to consider and there's not a lot of evidence yet. There's not a lot of, as I said, we're piloting programs. So I guess to be decided. I don't know if we'll see, is part of the answer.
Oh,
no, go ahead, Ashwin.
Sorry. So Helly, I was just having a question for you actually.
So
in terms of like how Brittany is talking about this kind of having mental health professional going to a scene, how do you think would that impact care that you see when patients come to the hospitals? They are injured, and you also see the mental health component there that is not addressed. What is your opinion on this kind of a program?
Oh, I mean, I fully support a program like this. I mean, from my perspective, we usually see them in the hospital after there's been injury. So it would definitely help reduce the burden on already very busy emergency departments. And oftentimes, one of the things that we don't consider when you have one of these events happening is the multiple individuals that are injured. And so then what can happen is, and it's happened to us before, where you have all these different traumas coming at the same time. And even though the team, if it's a trauma center, they should be equipped to deal with it, but they even have their limits. So even just like helping limit the amount of injuries or events happening will help with how the hospital can care for them. And I mean, we've seen it a few times where, and it's not even very far from the hospital itself, where individual is having some kind of agitative event, and in the process, because it wasn't able to be de-escalated, oftentimes they're the ones that are the most hurt.
Sure.
So then they come in, and usually what they're hurt with would otherwise is then actually even made more difficult to treat because of their condition. So something that we also have to think about, once someone's in the hospital arena, or that just physically that building, we can't let them go until we know it's a safe discharge.
Yeah.
And a lot of time with these individuals, if they're not getting the adequate care, the mental health care, a lot of them, like mentioned before, are homeless, or we talked about stigma, or they don't have a relationship with their families. So it's not certain that when we let them go, when we let them leave the hospital, patched up, that where they're going isn't necessarily going to just send them right back in. And I mean, this is a little bit of a crude joke, and I hope you don't judge us providers for it, but we call it, they're frequent flyers.
Yeah.
And it's not to, this is more of I only share this term to show this is more just how we cope with it. It's hard to see. And sometimes we kind of have to resort to these terms, which may, I mean, I recognize that it may worsen the stigma, but it does cause a lot of burden. There's compassion fatigue. Eventually, when you see the same person within, and I'll say like, even within hours, like we just discharged someone 12 hours ago and now they're back because they got in a fight with someone. And just, you're already really tired. The ED's already filled with people, and it's hard not to burn out from that. And I have to sometimes actively remind myself, and I was on a call on Wednesday, and I was sitting with the ED provider, because every time there's a trauma, the surgery team comes, and which is my team, and then the emergency department providers are there. And after we made sure the patient was stable, and we were just observing him, sitting and watching basically until we knew what to do next. And I kind of turned to him, I'm like, this gentleman, like, he was at one point a cute kid. It's like he wasn't born this way. And I'm glad, Brittany, you mentioned nature versus nurture, because then I had the honor of meeting his family, and they were normal. Like, his brother did not have, his brother was like a well dressed, and you could tell was like emotionally hurt by everything that was going on. Had no idea that the days prior to had led up to him being in the ICU. So it's something I think we have to remind ourselves, none of these individuals were necessarily born with the intention of hurting themselves or others this way.
Sure.
So yeah, definitely. I think, Brittany, you mentioned that when you're talking about this interaction with the police and like how to de-escalate situations, I think it's very clear, it's very complicated. And there's probably not a single answer. I think as a culture and as a species, we like one answers for things. And there's probably not going to be that. But I do strongly also believe in prevention. I think in the same way that we talk about the police de-escalating and having a mental health professional there to prevent the hospitalization. There's also prevention before it even gets to that stage in the form of youth and young adult mental health. So my question to direct back to you, the youth and young adults mental health, it is worsening with nearly 10% of America's youths now reporting severe depression. Suicide rates are especially high among Black youths and LGBTQI persons. They're at a disproportionate risk of death by suicide, as well as suicidal ideation, planning, and attempts. So you work with a lot of young people. Why is this trend worsening? And what do you think can be done about it?
It's a great question. And I don't think there is one answer, as there tends to never be in psychology. There's usually not one answer. But I will say that it's a combination of factors. I think social media is a really big one. I've had this conversation with many of my colleagues. I've been working in college counseling for some years now, and we often discuss the mental health concerns of our young adults who are, it's worsening, absolutely. And there's not a clear sign as to why, but as I said, a combination of factors, with one of them being social media. I will say almost all of my clients bring up social media. We think about the idea of upward social comparison. So that's when you compare yourself to people who you perceive as, quote, better than you. So as I said, I have a specialty of like working with eating disorders, and I will say eating disorder symptoms are definitely activated by social media, because we see these filters on photos and, photoshopping and all kinds of, angles and lighting and things that are meant to make people look the best. We're also only putting really our best on Instagram. I joke that during my grad school days, I would put the pictures of me happy and out, not like sobbing over, my tests as I'm studying and being super stressed. I'm not putting that on social media. So people probably looked at my profile and thought I was doing so great and was so happy, but I was really stressed during grad school, but I wasn't putting that on social media.
Yeah.
So that's one component. I also think we have to consider cyberbullying. This is a kind of newer phenomenon that older generations didn't really have to work with. That this was not something that there was in-person bullying, which is awful. So we still have in-person bullying, and then they get to go home and be bullied online, which is awful. It basically creates a situation where they don't feel safe. They don't feel like they can go home and have their safe haven because their computer or their phone is going to possibly lead them to be bullied. And I think that can absolutely lead to higher rates of suicide for our kids. We also have to consider just societally what's going on. I mean, we're in a pretty rough political climate right now. This, it's not the easiest time in this country, just politically. And I think there is a lot of division, and to think that doesn't impact young adults or teens is kind of overlooking something very important. I mean, it is. We can even look back to the recession. The recession when kids saw their parents losing jobs and having to move and find new friends, things like that. Like, big events in the world and in the country are going to impact our young adults. With COVID, oh my gosh, the amount of students we had reaching out that really needed help and support when COVID first kind of appeared, that was overwhelming, I will say. And I know we've all had difficulties during COVID, so I know that I'm not alone in that, but that was another thing that really impacted our youth. And then when we look at minority youth, so LGBTQ youth, they may not feel comfortable coming out to a therapist. They may be worried about being outed. They may worry that their therapist is going to judge them.
Yeah.
We look at Black youth. They may feel, first of all, there's a stigma within the Black community surrounding mental health, seeking services. A lot of times there's the idea of we don't talk about our problems outside of the family. And so going to a therapist and talking about problems is very against what they've been brought up to believe a lot of times. And I mean, we can't say that every single Black individual has dealt with this, but I mean, there are certain cultural aspects that can get in the way of seeking services. Also, when a young Black man goes to therapy and they see their therapist, and the therapist might look like me, they may wonder, okay, what does she know about my life? What do we have in common? I'm going to tell her my problems. How is she going to help me with that? So I think there's also that concern as well. Is my therapist going to judge me? Are they going to understand my problems? If I have a Black male coming in with concerns about discrimination, they're probably not going to think I can relate to that. And I haven't really had personal experience with racial discrimination, and I can empathize, but they may not feel like they want to talk to me about that. So that's another barrier too, is that there is not much diversity within the mental health field. I mean, there is and there isn't. So I think that's another component too. It's very complex.
Yeah, definitely. I'm glad you brought up some of the topics about cyberbullying, and I would like to tie that back to the point you talked about character. People talk about character. Cyberbullying is new, but bullying is not new. We know this since the Greeks and Roman empires, where there is bullying that happened there to my father's generation and my generation. And I would say my generation is when the 90s generation, millennial generations, where cyberbullying began. But bullying is not old. So someone from my grandfather's generation would say that if someone beats you, you beat them back. That's the kind of, so you have that kind of character building opportunity for people who might have that um, privileged background, having those support system from the family, giving them that character input, where the person does not develop a mental health condition and is able to handle the problem head on, because he has that support system, he or she has that support system. And so, should character and moral studies be included in elementary schools, and middle schools, and high schools probably, so that people are given this kind of a moral stamina and spinal cord, uh, to stand up and handle issues, and not bring it to a mental health illness. So would that kind of prevention work, or is that also part of lack of awareness?
So that's a great question. As far as programs in schools, there are plenty of anti-bullying programs in schools. I think some of them are more effective than others. During undergrad, I actually did research with an anti-bullying program that at no point ever mentioned the term bullying. It was all about pro-social behavior. So rather than teaching kids not to bully, they were teaching kids to go out of their way to do good things for others. So it was more than don't be mean. It was be good, go out of your way to do nice things for others. And anecdotally, I think we saw that schools were responding well to that. A lot of the young leaders in the schools really appreciated it. There were culture shifts within the schools. So I will say that I think anti-bullying / pro-social programs can be effective, and I don't think there's anything wrong with including those in curriculum. I don't think anything bad could happen. Do I think it's going to completely fix the problem? No. But as we look at this is a multifaceted issue, so we have to take many different approaches to addressing these issues. And I think some of the issue too, as you're talking about, if someone bullied you in person, you hit them back kind of a thing. That's maybe not the best way to go about it as far as, what we would teach in the mental health field. Not to say that, if people have to defend themselves and they defend themselves, fine. But I think one of the difficulties of cyberbullying is that there is a level of anonymity to it. You don't have to, you can have fake profiles and Instas and all of the stuff that my college students teach me a lot of things, and they think
sure.
So you can be anonymous, so you can't even confront your bully because you don't know who they are. And I think there's also this like ganging up, and I'm sure we've seen on social media when people get into these like comment wars with each other, and the adults do this and they say things to each other that they probably would never say in person. People get real bold behind the keyboard screen.
Can I interject one thing?
Yeah.
So there's this fantastic episode of This American Life, a podcast on NPR. It's quite old. It's like maybe 4 years ago, where it was one of their own writers was being cyberbullied.
Okay.
And which is actually common among, we don't talk about this, common among like not even celebrities, but like reporters or people who are willing to talk about the difficult issues, puts a target on their back. And especially because they have these like online profiles. So, but one of them decided that she was gonna take the mask off one of her bullies. So the anonymity, tracked him down and confronted him about it. And it was a really beautiful episode because it kind of revealed that a lot of these people, because it turned out that it really had nothing to do with her or even what she was trying to say. It was a saying, bullies are bullied.
Yeah.
Absolutely.
So he was going through his own things. And when they had this conversation, just like direct, it was actually, I don't know, it made me believe in people again, because I think sometimes when you just see the problem, you kind of want to like give up. Like give up caring. You know, we talked about compassion fatigue a second, you know, earlier I mentioned that, and I think that it leads into other things. And yeah, sometimes it's I think something I've noticed, my sister's I'm a millennial, she's a Gen Zer, and I've noticed that among her group that, and I think she's lucky that she's grown up in a culture where mental health, like her friends and her education, where she grew up, sounds like they've been doing things like the which I'm sorry, can you remind me pro-social behavior, and I've been impressed with the way that they're able to turn kind of things around and been like, okay, what's the other person thinking? What are they feeling? Like, there's more than one reality here. There's like my reality, and then there's the other person's. And you know, I hope that what my wish is that with every, and you know, Ashvin, you were talking about like, you know, this is going on since like ancient Rome, and then you describe your grandfather's reaction to things, and even like my parents' reaction to things were like, just turn a blind, like, you know, just turn the other cheek, just tough it through, pull yourself up by the bootstraps. And but I do feel that with every generation we make incremental improvements, so it's easy to be overwhelmed, and I think by seeing these like gradual. But yeah, when you're talking about the anonymity, it struck that episode with me. I wish I remember the name of it, but it was interesting what happens when you confront the bullies, and sometimes you end up having a lot more compassion for them than you go in wanting to hate them.
Yeah. A lot of it is understanding and empathy. We have a joke within the mental health community that it's hard to be mad at anyone, no matter how rude they might be, because you have an idea of what's going on. You know that there must be some reason for it, so it's hard to be mad at people. And it's, you know, it's a joke. I could certainly still be mad at people, but I think when we develop our empathy, it makes it harder to blindly pass judgment. So I really, I'm glad that you brought that up, and This American Life is such a great podcast too. So I'm glad you brought that up anyway, but it sounds like that was a great episode. I haven't listened to it, but I really like the idea of that, and people being able to say like, yeah, I'm going through some things. This is why I'm being like this, and maybe teaching more empathy in our schools and having that be part of the pro-social anti-bullying programs. And I'm also glad that you brought up compassion fatigue, because I think that's something that all of the helping fields really do experience, and we also cope with humor. So the idea of like a frequent flyer, and I know you apologize not wanting to be rude, but we definitely have to use some humor to cope in our field as well. We do it respectfully. We would never do it to the client or patient. You know, it's kind of just between us. But sometimes we say you have to laugh or you'll cry. So I think whatever we can do to keep ourselves from burning out within reason, I think is okay.
I think Ashwin, I had the honor of being at a previous episode talking about like an infectious disease, and I would right now, like with the direction that our conversation has taken, I'd argue that this is also mental health is an infectious disease. We talk about how, I mentioned my experiences in the trauma bay, and honestly, sometimes when it's 2 a.m. and I see the same guy over again, we put in so much work into patching him up, we let him go out, and then he comes back or she comes back, it's hard. It's really hard, and it's like I could be sleeping right now. Yeah. And it's hard not to have a lot of resentment for the person.
Definitely.
And again, I think it helps to have conversations, and also one thing I've been working on is also not to stigmatize anger.
Yeah.
So it's we've been, with my small community, I've been trying to say to people, like, it's okay to not like your patients.
Yeah.
people don't like to hear that. And I think some people are close to me that see me as a very like nice, compassionate person are surprised for me to say that. I'm like, listen, it doesn't affect the quality of care I give the person. If anything, it can help, because then I'm not spending so much energy trying to, but it's okay to not like the person. And I think that's a very big ask of the doctors and nurses and mental health professionals, even to have to like we don't actually have to do our job well.
Right. You're not going to love every patient. You're not going to love every client, but you will treat them with respect. You will give them quality care. And as far as the anger goes, we often think about anger being linked to needs not being met. So if we have a client or a patient who seems really angry and might be yelling, might be somewhat violent even, a lot of times that's because their needs haven't been met, and they have to do that and have had to in their life do that to get their needs met, because the squeaky wheel gets the grease. If you have someone who is screaming and violent, they're going to get their needs met more so than someone who's quietly suffering. So that's also a good way to increase understanding and compassion and empathy for, anger is an emotion. We are humans and we have full ranges of emotion, and there's usually a reason behind it. So.
Well, Brittany, this has really been a riveting conversation about mental health, and especially also having someone from the medical field with Helia here also kind of really showed that 360-degree view of what happens with person's life who probably, he or she is part of this entire system. And, to have your input today was really valuable. And I'd like to ask you, why did you choose to become a clinical psychologist? And why should other young people pursue this career?
So I've always known that I wanted to be in a helping field. It was a matter of which one I wanted to be a part of. And I think growing up, I've always been someone who people will come to and talk to about their problems. And I love to support others. I'm really big about kind of like rooting for the underdog, if you will. So that's always kind of been, I think, a part of a value to me, is just supporting others and being there for other people. And then when I took my AP Psych class my junior year of high school, I thought it was really, really cool. I loved the material. And that's when I decided, okay, I want a PsyD in clinical psychology. So when I was 16, I made that decision and ended up doing it, which is pretty cool to be able to have that insight early on. I don't think a lot of people are able to do that. And I work with a lot of college students who kind of struggle to figure out what they want to do. So I see myself as very, very lucky and privileged that I was able to identify that early. And I just love what I do. I mean, the more that I do it, the more I love it. I get to make these really close, intimate connections with my clients. I find out things about them that they've never told anyone in their whole life, and I can be that corrective experience for them. I have an interest in working with LGBTQ clients, and I've had many clients who have come out to me before they've ever come out to anyone. And that it's such an honor to do that. I get to live every day feeling fulfilled. And I think that's kind of the goal, at least for me in my life. I want to feel fulfilled, and helping others does that. And if we have to have a career, which we should have one we love that makes a difference and leaves us fulfilled. So that's what brought me into this field. And I'm very happy, no regrets about any of it. So
it's truly inspiring.
Thank you. Yes, thank you so much for having me today. This has been such a wonderful conversation. I've loved hearing all these different perspectives and such great questions. So thank you so much for having me today.
Oh, we have one more question for you.
Oh, okay.
Yeah, so we really appreciate you. I mean, I look up to you and your colleagues, but we'd love to hear who your personal and professional role models are.
Oh, absolutely. So as a clinician, I am a big cognitive behavioral therapy person. Mm-hmm. So I would say the Becks. Aaron Beck is the one who sort of came up with cognitive behavioral therapy. And it's such an interesting approach and can treat such a variety of disorders. And it's also really accessible to people who maybe can't seek out mental health services because they make CBT workbooks. So people can go to Amazon and for like $20 buy a workbook and do some CBT exercises at home on their own, self-guided. So I love that it also can work within a short-term model. When we've talked about insurance companies maybe cutting people off, or a lot of college counseling centers have session limits because of lack of funds. So I love that his approach has really made that very accessible to people. And so he's definitely a big professional kind of person that I look up to. And in my personal life, it's mostly been like my parents, for example, are both in the helping field. My dad is a physician, my mother is a nurse, and having seen them both be in the helping field and the way that they raised me to help others and live a life of service, essentially. I really look up to both of them for that. And a lot of the people I've trained with are just so brilliant, compassionate, empathetic. I often look at my colleagues who are now close friends of mine, and I'm just amazed by them and so honored to have been able to train with them. And they're there for supervision. So if I'm like, oh, I'm super stuck with a client, or if I'm like, oh my gosh, I just had a really heavy session, I need to cry it out for like 2 minutes and then I'll be good. They're always there to be that listening ear. And I think that's so important within the helping field and really helps with the burnout. It keeps us from getting too burnt out. So my longer answer to the professional and personal people in my life who inspire me.
I'm glad you mentioned how the way the sessions affect you and your mental health, because oh, we have a little visitor. She was on my, I think she heard something, but because it's, I think at this point I've hit we could go on for another hour on this topic because it affects such a vast group of people. But I think that's something I appreciate, because that's knowing that it happens all around. Because I just shared with you the way that we feel, the way that it's affected our mental health and burnout.
Yeah. Oh, I've actually thought counseling during COVID. I was feeling really burnt out because I had so many clients all presenting with the same thing essentially, and I was experiencing those same anxieties of
yourself,
all of that. So I said, I was like, I need to go back into therapy, and I've been in and out of therapy throughout my life and found it to be really helpful. So that also drew me to the field as well. So I'm a big advocate of helpers also seeking help when they need it. So I'm very vocal about my experience having been in therapy as well as being a therapist. And I think that's also important in reducing the stigma. So yay for therapy.
Yay. Ashwin, I think this is us hinting at you, maybe not so subtly, that maybe we need a part 2 on this.
Yes, definitely.
On this topic. This is a really great one.
We'll welcome Brittany again to this.
Thank you so much.
Have a panel discussion. But today's conversation was like I learned a lot, and really, Brittany, you uncovered and enlightened us about the real issues and bottlenecks and the areas where we need to really improve the access to mental health services, and also not shying away from hard conversations, especially talking about prevention or case loads or the need for increasing diversity. So thank you so much for your time, and we look forward to inviting you once again to our show.
Thank you so much for having me. This has been wonderful.
And I also thank Elia for being here and supporting our program. Thank you so much.
Thank you.
It's always a pleasure. I look forward to being this, and this is a topic really near and dear to my heart. So I really appreciate the opportunity to be here as well. And Brittany, I loved hearing from you.
Thank you so much. It's great to hear from you as well.
And we also want to thank our audience for participating in this episode, and we will bring another unsung hero of public health hero next weekend. And until then, stay well.